quickly update the review and update the CCS lipid guidelines, which came out last year, and then talk a little bit about these novel agents. Which I don't really have any disclosures, and this is not intended to brag, but if you know my involvement in some of the stuff, then you understand my passion behind some of it. So I've been a member of the lipid panel since 2007, and vice chair this past year, and I'm currently the new chair for the next set of guidelines. I've also been a member of the Canadian Working Group in the Diagnosis, Prevention, and Management of Statin Adverse Effects and Intolerance since 2013. We publish an annual sort of index review of all of the related problems and the evidence or sources of information that make all of the noise about statins. I've also been a member of the FH, familial hypercholesterolemia secondary position statement, and a member of the FH Canada Registry, the PI for Alberta. And I also believe in the LDL hypothesis, which is not something that is what everybody holds. And in Alberta, you're all well aware of the top guidelines, which are different, and we can talk a little bit about them later, but I don't believe that they're actually in opposition to what Canadian guidelines recommend. They actually are targeting and trying to achieve a different goal than what the broader set of guidelines are. So this is an editorial from American Journal of Cardiology just talking about the LDL hypothesis, and essentially it refers to the fact that LDL is directly related to cardiovascular disease and all of the evidence that supports it. It's an irrefutable fact. We've been debating over the years because we've only had treatment outcomes from statins, which have proven to be effective in reducing mortality events, not with any other drugs. And so people who want to refute that whole ideology have pointed to the fact that no other drug which lowers LDL has actually demonstrated cardiovascular benefit. That's no longer true. We'll talk a little bit about it. So the LDL hypothesis, I still believe, is alive and well, and if you don't believe it, we can debate it. So the objectives tonight are pretty broad: to provide you an update on the guidelines, to review recommendations for non-statin drug therapy, because we've been in this world for more than a decade where statins have been the only thing that have been of great benefit to us, and everything else is just kind of adjunctive if you really want to do something, but no evidence for it. Talk a lot about, not a lot, but a bit about the PCSK-9 inhibitors, which in and around, I'm not sure how much you're seeing of them. Talk to you about my utilization in my practice environment at the present time, but recent data from March this year presented at the ACC, so we'll talk about that information. And then really try to put it all together in terms of the overall approach to cardiovascular risk management and how to deal with all of this stuff. These are the guidelines. They were published late last year. See my name on there, but there's a second pharmacist who was in Alberta here, a fellow with me, Arden Berry, probably known through CSHP. So we now have two pharmacists, so we're the only guideline that I'm aware of that actually have two pharmacists. It's good to have one. They're not often there. So that's a big step forward, and then to have a second one is quite phenomenal. The process, I'll bore you with the process because it's a little bit important to understand because of all the different guidelines. And if you practice in an area, you understand guidelines and you follow them specifically, but from a family physician perspective, they're often challenged because there are guidelines for every area that they practice in practically now, and it's a real challenge for them to actually manage their patients in a guideline-based way because they change or because there are opposing views sometimes. So again, even with our own, you're well aware from the previous set of guidelines, the alterations and the fuss that was caused when the Americans updated their ACC-AHA guidelines. That seemed to be in opposition to Canada as well because they recommended no targets. Well, guess what they're doing? They're coming back with targets. But in any event, what we did in this go-around was we started with PICO questions, so patient, intervention, outcomes of interest, etc. We did a full literature search on each of the questions. We selected the studies. We didn't do all studies historically because this is an update. We've been doing these guidelines every few years when there's something significantly changed. So we only included things that changed the recommendations that were going to be included in the guidelines. Each individual study was reviewed by two panelists, and then they were graded by the grade checklist for quality assurance by two different panelists. So the approach to risk management, we tried to focus on who and how and when to screen patients, how to evaluate risk, when do you initiate treatment, and monitoring and surveillance. This is an example of an evidence profile for a specific question. So the PICO question was, are the cardiovascular outcomes, including non-fatal MI, cardiac death, ischemic stroke, revascularization, or hospitalization for acute coronary syndromes reduced in subjects with chronic kidney disease of any severity treated with a lipid-lowering agent compared to others? Again, anyone who's been in practice for more than 4 or 5 years are aware of the ongoing off and on again issues about should or shouldn't patients with renal dysfunction be on statins, and when do they come off them, when do you initiate them, is it if they're on dialysis that they're going to have a transplant? And so that was still an important question. So each of the studies that was included are there, and they're all rated according to potential for bias, etc. So what did we do? These are the summary now part of the guidelines. We set up tables of each of the sections that we think that people need to walk through. So who do you screen? Well, you're all well aware, hopefully, of who to screen. The change that we did make was we altered the age to make it equivalent, not because anything changed, just for simplicity. We had tons and tons and tons of discussion on keep it simple, keep it simple, keep it easy to remember. So all those little subtleties of age differentiation and cut points is too confusing for people. Family docs can barely remember at what age risk increases or at what age family history is an important issue. So that change was made based on that information. The other area of that's new is the inclusion of hypertensive diseases of pregnancy. And that was based out of work from some of the OB-GYNs and led by a practitioner in Calgary who contacted us based on work that they were doing, which has demonstrated that women who end up with some form of hypertension during pregnancy have a significant increase in mortality from cardiovascular disease prematurely when they follow them longitudinally. So including them as a higher risk or patient population to screen. We didn't make any other recommendations about what to do with them. It's all in the same way, but you should be screening those women who've had that problem for when to initiate early. How do you screen? Same thing as we always have done, but the non-fasting lipid is now acceptable. Things are fairly straightforward in Alberta because, except for the transition zone where we are here, Calgary and Alberta, or Calgary and Edmonton labs are essentially identical, managed slightly differently, but they're one, and then there's a little variation here in Red Deer. But interestingly, as we were going through this, unbeknownst to me, almost a year before, the labs for Alberta had already made the change. So I don't know if you guys know that. This has changed long before we made these guidelines in this province. The labs now do non-fasting, okay? And I'll talk about why in a moment. And so that is the recommendation for most patients now. So why were we doing fasting? Part of the problem is no one has to fast for any levels anymore. Diabetics don't need to because hemoglobin A1C has become a recommended screening tool for diagnosis and for monitoring. So the only lab value you have to fast for is a lipid profile. So this group out of Copenhagen in 2008 basically did a cross-sectional study of fasting versus non-fasting lipids in the general population. And then Sidio Nagler in Calgary did a similar community-based evaluation of 209,000 patients tested from 1 to 16 hours postprandially. And the summary of that, both studies, is that non-HDL and apolipoprotein B vary very little between fasting and non-fasting. Only triglycerides increase. That's what's variable in a postprandial state. We all know that from diabetes, right? It's the same. Triglycerides are just like sugar. They're short-lived. They go up and down based on consumption of meals. When you specifically look at the LDL group, it was lowered by up to 10%, which on most patients translates to an LDL change of 0.2 to 0.3 millimoles. So clinically insignificant in making decisions. So it's convenient to not have to worry about it. The labs don't have to jam up. Every little old lady and little guy and middle-aged guy, whatever, who you're sending off for labs, don't have to get there first thing in the morning. they can go at their own convenience. Changing the reduced waiting time for pit morning burden at our labs prevents hypoglycemic episodes for patients, because you're getting questions from the diabetics about, how long do I have to fast in order to get my lipid panel done. Hopefully enhances compliance. I can tell you in my own clinic practice, with telling patients that they can now go non-fasting, my observation, not measured, is that they go more consistently at the time frame that I'm asking them to, rather than I've been waiting for, it was done 2 months later, because they just didn't have time. An enhanced predictive value for cardiovascular morbidity and mortality has also been demonstrated from non-fasting values. Identification of high remnants and insulin resistant are possible in this manner as well, and it removes the need to do just fasting blood work in general. So guideline-based risk assessment is unchanged from previously. We still have are recommending 10-year risk according to the Framingham risk model. Every 3 to 5 years in men 40 to 75, and this should be women 40 to 75 as well. So no change except for the simplification of the age. So when do you consider pharmacologic treatment? This is a slightly confusing, it'll make more sense in a moment, slide as well. But one of the things that we did was try to group things together in a more logical manner so that people didn't have to remember just risk categories and certain conditions and diseases. And primary and secondary prevention. So all those different categorizations and slices of the data get people very confused. So we now talk about clinically indicated conditions, or statin-indicated conditions. So these are all statin-indicated conditions. You don't need to do Framingham risk if you have somebody who's got clinical atherosclerosis, has had an MI, has had a bypass procedure. We all know that from a long time ago. Abdominal aortic aneurysm, diabetes, subcategories that explained there. Chronic kidney disease, greater than 3 months duration with an ACR greater than 1 milligram per millimolar and eGFR less than 60. And then the new recommendation coming from our FH working group that for an LDL over 5, which by clinical criteria identifies the majority of patients with an inherited hypercholesterolemia pattern. So those are all indicated conditions. So we recommend the same thing for all of them. Initiate a statin and treat them to a target less than 2 millimoles per liter. In the primary prevention group, the only subtleties are some of the other risk additional factors. So like before, where we had, if you had to have an LDL greater than 3.5 in order to qualify. Well, if you don't have an LDL greater than 3.5, you can still get a statin if you're that intermediate risk category, if you have an ApoB of 1.2 or greater, or a non-HDL above 4.3, which is identical to the previous. But the new addition is the clarification based on HOPE-3, which is men and women, men over 50, women over 60, and that's specific to those trials. We couldn't change that part for age, but with at least one cardiovascular risk factor. So that population in the intermediate primary calculated Framingham risk group should also be considered for statin and treated to the same level. So here's HOPE-3 very quickly, in case you've never heard of the results, but this was an intermediate risk population without any cardiovascular disease. So they were primary prevention, and that's the age category. And so before somebody asks me later, didn't you guys, the recommendations are women over 60 and men over 50, this is 55. Well, this isn't the only trial. There have been a number of other smaller trials, which included younger men, so we broadened it to include it, so it's not just HOPE. So the risk factors that they could have had to get in were waist-to-hip ratio increased, a history of current smoking or recent smoker within the past year, low HDL, dysglycemia, renal dysfunction defined as such, or family history of premature disease. They excluded any cardiovascular disease diagnosis or any other contraindication to the drug. So a really straightforward population, but at risk. And this is what they found. They found a significant reduction with a 24% reduction in events of cardiovascular death, MI, and stroke for patients treated with rosuvastatin in this trial. Subgroup analysis, everybody benefits. Some crossover because of small things, but there's no signals that some group did worse and some group did better. They all did well reasonably. So when we summarize how the new guidelines look, we still have primary prevention, but as primary prevention statin-indicated conditions now, it makes more sense. and then you have to look at your high and intermediate risk qualified patients. And all of these groups all have a targeted LDL of less than 2. Straight, simple, straightforward. We, ad nauseum, we delayed actually our publication because we continued debate for about 8 months whether or not we pick a lower target. 1.8 is the American one, it's supported by data, but it's all over the place. And the difference between 1.2 and 1.8 is such a big change for people. The meaning of that change in practice is small, so we left it there for now, knowing the results that are going to come, because I think we're going to end up having much lower targets in the very near future. The last group on the bottom, which again is just subtly different, we don't have a specific target. Again, remember, if you have an LDL greater than 5, based on when we did this, the fact that you're going to be recommending statins lowering LDL by 50 to 60%, there's a significant number of patients who, by FH criteria, may never be able to get down to 2. And there's no other support or data to say that additional agents are beneficial in that group. So we are focusing on aiming to achieve the lowest you can get with them with maximum therapy, but at least a 50% reduction, however you can do it. So that's the only subtle difference that is there. Otherwise, everybody in these groups is treated the exact same way. So this, just to go back a little bit about what do we get when we treat these patients, the CTT, the Cholesterol Treatment Trialist collaboration, showed us that reduction in major vascular events by baseline risk, that no matter where your cholesterol levels start, where am I here? I think myself. At every level, your risk gets significantly reduced, and actually fairly consistently. When we look at it by baseline level of cholesterol, if you start with a cholesterol value or an LDL value greater than 3.5, 3 to 3.5, 2 to 2.5, 2.5 to 3, 2 to 2.5, or less than 2, there's a very consistent 25% reduction in major vascular events across all people. So again, this attests to the fact, the lipid hypothesis, that lipids, elevation, and at any level at this point in time is probably bad for you, so we're continuing to push things down. This is an interesting way to look at trials, and so people have come out and argued consistently since the most recent American guidelines that Canadians are wrong and the rest of the world are wrong, because everywhere else in the world except for the US has targets still, much like ours, that those targets are not based on anything. And no, most of those trials were not designed based on starting and achieving specific targets. They were based on doses of drugs and on treatment achievement. When you look at all of this, this trial by Bokert in the American Journal of Cardiology demonstrated 8 different trials, there was at least 40% of patients who did not achieve LDL target of less than 1.8 based on the American definition on high-dose statin. So this is the bell curve, the distribution of patients' response over time. When you actually look at the hazard ratio based on the degree of reduction from where they started to where they went, you could draw the exact same line as we see in the summary of, and you've seen that diagram where every trial that's ever happened with statins has been plotted on a regression line like this, and the where you start, or the placebo arm versus the treatment arm, falls very close to this line, and that's exactly what we see. So patients achieving an LDL of less than 1.3 were demonstrated to be significantly lower risk than those achieving an LDL of 1.9 to 2.6. So that's why we left everything the way it was at the present time, because nothing else could argue for it. So again, recommending treatment to target approach, as we always have, that hadn't changed. The rest of it will get covered in another slide. Switching gears slightly about different drugs than statins, we had the Improve It trial, which was a population of patients post-ACS, less than 10 days, with an LDL between 1.3 and 3.2, or slightly varied with a lower end of 2.6 if they were already on a lipid agent. randomized to standard medical interventional therapy. They got simvastatin or the combination of simva and ezetimibe, and then followed up with a primary endpoint analysis of CV death, MI hospitalization, or unstable angina for revascularization or stroke. They found the lipid changes. There was a 0.4 millimole difference between the patients on ezetimibe and those not. Remember, both groups were getting simva. So an additional 0.4 millimoles lowering of LDL, which translated out into a statistically significant, approximately 7%, 6.5% reduction in all of those events over the follow-up period. Very small, but based on the effect, it's consistent with the expectation of what degree of risk reduction you're going to achieve based on the amount of LDL lowering that occurred. So you need to treat 50 patients, though, to achieve that result. So some people use it, and at least that's now the first bit of evidence for a non-statin lowering modestly, or minimally, I'd say, LDL for a reduction in events. So we recommend ezetimibe as a second-line therapy to lower in patients with cardiovascular disease if targets weren't reached. We also recommend that niacin should not be added and that fibrates should not be added. And the reason for that, we'll come back in a second, the bile acid sequestrants could be considered for patients who remain above target. There's not great evidence, but they're reasonably effective. We did come out with a bold statement based on no outcome data that the use of PCSK-9 inhibitors should be used for LDL lowering in patients who are heterozygote familial hypercholesterolemia. These are patients who exist in the population about 1 in a million and have LDL cholesterols that are like 13, 15. I've seen one in my life. So if you've seen one, you're lucky. They're like zebras. They're not common around here. We suggest that evolocumab, which is Repatha, be added to background therapy in patients with homozygous familial hypercholesterolemia and continued if LDL lowering is necessary. And we also suggested that these agents be considered for LDL lowering in patients with atherosclerotic cardiovascular disease not at target despite maximal medical therapy, which would be a statin plus or minus ezetimibe. That's based on trial design, but you can see it's a moderate quality of evidence and additional recommendation because no evidence existed except for stuff that I'll show you briefly in a moment. And then there's other agents that are coming out that we'll touch on tonight. So AIM-HIGH was a study of just over 3,400 patients with established cardiovascular disease who got niacin up to 2 grams per day versus placebo on top of their statin therapy, and after 4 years, the lines were superimposable, absolutely no benefit. So I must, around my 15 plus years career, working in a lipid clinic with niacin for an awful long time. We don't do it anymore, it's dead. So niacin provided no benefit to those patients with cardiovascular disease and low HDL who were on appropriate background therapy. HPS Thrive was a 25,000 patient study with established cardiovascular disease on the extended release niacin up to 2 grams per day plus larapiprant, which is the anti-flushing component of it, versus placebo. Again, on background therapy of statin and treated for almost 4 years, lines superimposable, no significant difference. So niacin provided no benefit in that group as well. So niacin's dead. Fenofibrate, the ACCORD trial, over 5,000 patients on statin therapy randomized to fenofibrate 160 versus placebo, treated for almost 5 years. This is the difference in outcome, CV death, non-fatal stroke, or non-fatal MI in percent per year. A difference, an absolute relative reduction of 8%, which was not significant. So again, no evidence for cardiovascular benefit even in a high-risk group. That's not to say that fibrates should never be used. I teach the students that because fibrates, the real mainstay of fibrates is in the prevention of pancreatitis in people who have significant elevations in the hematocrit. I usually don't pull the trigger on somebody unless they've been symptomatic in the past, which I would treat regardless, but if they've never been symptomatic, a level of greater than 8 on at least 2 different readings. So this is the PCSK-9 inhibitor cartoon of how these drugs work. The LDL receptor is this funny looking thing here, the LDL particle is a little yellow ball, and PCSK9 is the little dot. So what the PCSK9 does is it actually ushers the LDL receptor into the system for endocytosis and breakdown. When it's blocked and it doesn't attach to the receptor, that receptor can persist. So the more receptors you have on the cell surface, the more LDL is withdrawn, so the lower the levels are. So that's the theory behind how it works. The molecular discovery, it's a fascinating drug because it's been less than a decade from discovery of the mechanism to the marketing of products. And if you look through your pharmacology, you go back to all your monoclonal antibody stuff and things you learned in undergrad, I don't think there's any drug categories that have ever been developed that fast, and it's all been Canadian for the most part. I mean, studies have been done worldwide, but the discovery was a Canadian discovery. So the monoclonal antibody obviously binds to the enzyme PCSK-9 and prevents it from attaching to the LDL receptors. So the LDL receptors remain expressed because they can be used hundreds of times. But if the PCSK9 high levels of circulation, the more the receptors are removed from the system. So we had a number of preclinical trials looking at mechanism, etc. And the Osler study showed, in terms of LDL reduction, change from 3.1 to 1.2. The cumulative, this is an exploratory analysis and also looking at cardiovascular endpoints with evolocumab showing a 53% reduction in endpoints. Again, only exploratory, it was not intent, it wasn't even powered closely, but showing that even there, it looked like there was some signal of benefit. This is the Odyssey long-term trial looking at the other product, alirocumab, which is Praluent, the other one on the Canadian, only other one on the world market. Demonstrating a 62% reduction in LDL from 3.17 to 1.5. And again, very impressively, these are drugs that are administered subcutaneously every 2 to 4 weeks. There's a maintenance of the benefit over time. It happens very quickly and is sustained. Also, exploratory analysis of cardiovascular outcomes of alirocumab showing 54%. So two different drugs, in combination of different trials and kinds of patients, but a very consistent signal between the two of them. This was a slide that I used 6 or 8 months ago in a presentation like this, showing ongoing clinical trials, saying that we're going to have these studies available to us. So Fourier trials, I'm going to talk about it in a moment, was presented at the American College Cardiology meeting in March. The Odyssey outcome trial with alirocumab is ongoing. The Spire 1 and 2 trials are discontinued completely. On November 1st, Pfizer, who was the manufacturer of that agent, actually discontinued the global development of the product. As they were going through their analysis of that program and the studies, they actually found a number of factors, an increase in antigenicity. It's a slightly different compound than the other two that we have. They're both fully humanized. It was only partially humanized in terms of how they're manufactured. If you remember from pharmaceutics or whatever course it was called when you took it in terms of drug development and monoclonal systems, they use the mouse and then they clean it and make it human, as opposed to genetically engineering the mice to be more human-like and then they produce human antibodies. They also found that the benefit, the LDL lowering, was wearing off. There was a reduction in benefit as time went on. And so all of those factors together, obviously a business decision, but to quote a colleague in discussion about this, it's like kind of being the last kid to the party and not bringing beer. It looked really good. So they opted to bail on everything. So that product that was bocizumab. So that's not going to ever come. So we have Fourier, which I'll talk about momentarily, and Odyssey we're waiting on. I don't know the dates. I haven't talked to anybody from the company lately. It's been talked about late this year or early next year, but based on things that I've heard, it seems it's probably more likely to be later next year. I'm sure they're trying to push to get it for the AHA in 2017, but it'll probably be ACC later. So these are the slides that were presented actually at the meeting, or some of them anyway. Dr. Sabatine, who was the PI. So FOURIER stands for Further Cardiovascular Outcomes Research for PCSK-9 inhibition subjects at elevated risk. I like this slide I included, even though it's very similar to the other one, but they restate this and they talk about the PCSK9 being a chaperone of LDL receptor to destruction. That's basically what it does. It's kind of it's like a transport system. It takes it and brings it to the dump. So increases circulating LDL. When you block it, and it was discovered through the loss of function and genetic variants, when the PCSK9 didn't work, there was an increase in LDL receptors and a reduction in LDL levels, and then hence a reduction in events in that population. So this agent, the evolocumab, or Repatha, is a fully humanized PCSK9 monoclonal antibody, as I stated, demonstrated to lower LDL by at least 60%. Has been safe, well tolerated in phase 2 trials. I keep telling my patients, I find it hard to believe, but there are no side effects, essentially, from it. Very minor ones. The exploratory data analysis, as I showed you, suggested a significant improvement in cardiovascular events. So the objectives of this large trial were to basically test whether or not the addition of this PCSK9 would reduce the incidence of major cardiovascular events. They also wanted to examine long-term safety and tolerability, because again, in phase 2 and 3, they're all really short trials, 12-week follow-up. You know, we're all conservative pharmacists, and hard to believe there's no side effects. You take it for 2 or 3 years, something's going to happen with that. So that's what they wanted to evaluate. This is the design: 27,000 plus patients, high risk, stable, with established cardiovascular disease. They had to have a prior MI, a stroke, or symptomatic peripheral arterial disease. They were screened, had to have their lipids stabilized, and at a run-in period, high to moderate intensity statin therapy plus or minus ezetimibe in the background. Criteria for LDL on treatment was an LDL anything above 1.8 or non-HDL greater than equals to 2.6. And then they got evolocumab either 140, so this is the dose that's on market, 140 every 2 weeks, or 420 every month. And Jason can share with you if you're interested later, but they, up until recently, and I haven't seen the product yet, you have to use 4 of the 140 injections to get your 420. The 420 is available. They were both approved at the same time. They actually just didn't have the cassette delivery. This drug is delivered like an EpiPen. It's an auto-injector system. And so the new device had to go through Health Canada approval, because it's as talking to Jason just this week, and I'm not being around, it's an adherent injector device that can be put on the skin wherever you're injecting. It's a 9-minute injection, whereas the 140 is 10 to 12 seconds. It's very quick. So a little different. We'll see what the uptake will be for patients when we get to that. But the dosing was already approved by Health Canada with the device that's there. And then placebo was given the same way, and they were followed every 12 weeks. The endpoints of interest: the primary endpoint was cardiovascular death, MI, stroke, hospitalization for unstable angina, or coronary revascularization. The key secondary endpoints were CV death, MI, or stroke. They looked at safety, all the appropriate things, adverse events. Obviously, because of statins, they were interested in muscle side effects. It always comes up. And new onset diabetes, based on statins again, and neurocognitive issue. Not just based on statins, but based on some preliminary evidence that had come out through FDA analysis that suggested that potentially these agents, through LDL lowering or whatever mechanism, were having an impact on neurocognition. And so there was a separate trial called the Ebbinghaus trial. There was a sub-study, a subgroup of this patient population who went a battery of neurocognitive testing throughout the study to evaluate the impact of the drug. And then they also evaluated the development of anti-evolocumab antibodies for binding and neutralizing the agent. And then they had an events committee, as most large trials do. So they Randomized 27,000 patients, 13,000 evolocumab, same number of placebo. Median follow-up time was 26 months, but the interquartile range was between 22 and 30. 2,900 patients experienced a primary endpoint, and 1,829 experienced a secondary endpoint. So premature discontinuation, 5.6 in the drug, 5.8 in placebo, so no different. The withdrawal of consent was essentially the same, quite low, and loss to follow-up very small. So the ascertainment of the primary endpoint was complete for over 99.5% of patients. So very, very good follow-up, which is what we see in all of these large cardiovascular trials, why they cost so much and take so long. Here's the baseline characteristics. The average age was 63, mostly men. 81% having a myocardial infarction, 20% stroke, and 13% symptomatic. It does not have symptomatic PAD. Don't add up because people could have had maybe more than one. And the median time from their most recent diagnosed event was 3 years. Other risk factors, 80% were hypertensive, 37% diabetic, and only 28% actually were cigarette smokers, interestingly. You usually see it slightly higher. In terms of background therapy and lipid levels at baseline, in terms of statin use, almost 70% were on high intensity statin dose, 30% were on moderate, so probably had some side effects, couldn't push the dose any further. Low use of ezetimibe, again, given the time of the trial, the evidence pushing it, and all of the different centers in the world would not have had access necessarily to it. The median lipid baseline was 2.4, but ranged between 2.1 and 2.8, and the rest of the values are there for you. So what happened? There was a 59% reduction in cholesterol, an absolute change of 1.5 millimoles per liter. Evolocumab ended up getting and maintaining a level of 0.78. So in terms of on-target treatment values, we're now well beyond our on-target treatment recommendation, which is 2 in Canada, 1.8 in the US, which is why I said earlier that we are likely to see, as the rest of these trials come out, moving us further and further down for where we should be treating high-risk patients. But the interquartile range, there were people as low as 0.5 and all the way up to 1.2, but still much lower than what we currently recommend. Interestingly, this is a cohort of 11,000 patients who had all of their measurements, didn't discontinue or have any change in the background therapy, and it was very similar out to 4 years as in the previous Osler trial. This is the primary endpoint, so 2% reduction was observed at 36 months, hazard ratio of 0.85, so 15% reduction in cardiovascular death, MI, or stroke, hospitalization for unstable angina, or coronary revascularization. This is the key secondary endpoint, CV death, MI, or stroke. Again, an absolute reduction of 2%. Hazard ratio is 0.8, so a 20% reduction from baseline with treatment over 36 months. When you break it down, and this is extrapolated out over the 3-year Kaplan-Meier survival curve time, the primary endpoint was reduced by an absolute 2%, as I showed this one graph. What is a bit controversial and will be discussed for a long time until we get more data is that cardiovascular death did not change. Rates of MI were significantly reduced, as were stroke rates. Hospitalization for unstable angina was not any different. That's a very soft endpoint. I hate when they include that in their cardiac trials nowadays. Most of the time we don't. Coronary revascularization was reduced, both urgent and elective. But overall death from any cause was not different. Actually slightly higher, but the analysis suggested that they're not different. It's just chance observation. So no change in cardiovascular death and no change in death from any cause, which is a bit surprising. Interestingly, as I said, this is the CTT analysis again, and looking at, this is all the more intensive LDL lowering compared to CV death trials, showing that all of these agents had a significant improvement. But as we've gone on and got later, that improvement has become much less obvious. So the finding in this trial is consistent with IMPROVE-IT. We did not find a difference in death. SEARCH, IDEAL, those trials were not different either. These are all not significant, at least the The point estimate is in favor of intensive therapy, but the overall finding was not any different. So we're reducing burden of disease, we're just not changing outcome, because we've had a big change, I think, in the outcomes from statins already. There's just not a lot of death rate left. It's a small endpoint, it's a less common endpoint, right? But that's my simplistic view of it. Others may have other interpretations, but it's certainly something that people are raising their hands and shrugging their shoulders about these drugs going, but they didn't change death rate, why? They didn't change in other trials either, and weren't so upset at that point. Again, these are all key subgroups showing the same thing. I wanted to show this slide because it's the slide I mentioned before. If we plot all the lipid trials all on this slide, they all do the same thing. So the blue are the placebo start points for each of the quartiles. The red are the on-treatment achieved targets for the patients, and you can see they all fall within the same range. And that's what we've seen with every statin trial ever and with Improve It. They all fall in this exact same range. Again, proving the LDL hypothesis. Lowering LDL because it's linked to disease, it improves the rate of disease. When we compare it to the CTT results, so we know from the cholesterol treatment trials collaboration, statins on average will reduce major coronary events by about 22%, rate of stroke by 23%, coronary revascularization by 25%, and all major vascular events by 23%. The red bars and whiskers are the Fourier results at 2 years, 80%, 77, 73, 84, and overall 0.83. So very consistent. So again, the same degree of LDL lowering with a different molecule is achieving the same degree of benefit. Some of the numbers look a bit confusing when you just look at the trial because your start point is quite low, and so you've got the relative percent change you have to achieve to observe the same degree of benefit is quite large. In terms of safety from the Fourier trial, basically a wash. You know, all of these things are essentially the same. The most common side effect was injection site reactions. 2.1% with the drug, 1.6% with placebo. So if people have to inject themselves every 2 weeks, people are going to say it bugs them when they're asked. And it's not very common. The neurocognitive, the EBICAM sub-study, as I mentioned, absolutely no difference. This is going to appear in a separate publication. All the details are there, but cut to the chase, read the back cover, and the end result is there's no difference. And then in terms of antibodies, very, very rare in terms of binding antibodies, and no neutralizing antibodies have been observed in that period of follow-up. So, in summary, for evolocumab, LDL is reduced by about 60% for patients treated with this agent, and consistent throughout the duration of the trial with a median on-treatment achievement of an LDL of 0.8. The outcomes for patients who are already on statin were relatively impressively improved. 15% in the broad primary endpoint, 20% in cardiovascular death, MI, or stroke. Again, no improvement in death contributed to the other two things, so you're making major impact in life of patients, I believe. Consistent benefit, including those on high-intensity statin, low LDL, 25% reduction in death, MI, or stroke, even after the first year of treatment. And the long-term benefits are consistent with statin on a millimole reduction basis. They're also safe and well tolerated. No significant adverse events noted compared to placebo, including diabetes and neurocognitive events. And the rates of discontinuation are quite low in a clinical trial, but in my experience, patients that I've got on the drug so far have been quite low as well. They concluded in the paper that PCSK-9 inhibition with evolocumab significantly and safely reduces major cardiovascular events when added to statin therapy, and benefit was achieved through lowering your LDL cholesterol well below what current targets are anywhere in the world. That's the publication in the docu-DOI. If you want to go read it, it's obviously a well-written paper. And just to bring us back to the lipid guidelines and where we started, this is quite small for you, but this is a handout that we have to make it all easy. We tried to make a one-page flow so you can start from beginning to end. And I know pharmacists love all these tools, and internal medicine pharmacists have pockets full of them, which is why the lab coats are always ripped. But this is a useful reference tool when you can't remember one little detail, but it talks about what the risk assessment is when you do it, the pharmacologic populations. We don't recommend treating low-risk patients based on Framingham estimate. The intermediate risk categories we talked about, who and when you target, high risk, those with statin-indicated conditions, and the FH population, what the target goals are and whether or not you achieve those goals and how you add on therapy. So we focused, in the primary prevention population with ezetimibe being our first line add-on therapy based on extrapolation from the IMPROVE-IT trial. Minimum benefit, again, you have to make a clinical decision about how much LDL lowering you're actually trying to achieve. If you need patients, maxed out on a statin and their LDL is still 4, ezetimibe is not going to cut it. Why bother, right? Bile acid sequestrants are in there as an alternative, not because there's evidence for them, but they do effectively lower LDL, and we do have some tolerable products that patients may be willing to take nowadays. In the add-on for the clinically indicated statin condition, ezetimibe first line, BS as an alternative, and then PCSK-9 as a second line agent added on to other drugs. So plus or minus, a statin for sure, plus or minus whatever else you may have added. And again, we've tried to, in a different paper, point people to the fact that if you're on statin and your LDL is 4, picking and playing around with additional therapies is a waste of time. If you're at 2.5, maybe that's the right thing to do, but you have to kind of pick some cut point to actually manipulate those things. It was a bit bold to put PCSK9s in there, but the evidence for their ability to lower LDL is consistent, which is what we reviewed in the paper. And then in the FH population, ezetimibe plus is an add-on, or PCSK9. And for the most part, at the present time, most of the insurance providers, there are lots of ones that are covering it, but not obviously the patients we always see. A lot of the patients that I see don't have a lot of great insurance coverage. The two manufacturers have patient access programs, so they have an independent registration for a third party to help them with evaluating their third-party insurance if they're covered. Slightly different criteria by each drug, but if they don't have any coverage, they'll provide the drug for initial access and for ongoing management without any burden to the patient for a period of time. So what I've done in my practice is I'm focusing on this side, basically only. I have one secondary prevention patient two. I have 2 secondary prevention patients, both completely and honestly intolerant. I've tried 4 or 5 times different doses, combinations to try and get them to tolerate anything, and I have them on it. But I focused on my FH population because they're on statins, they're maxed out, and their levels are still quite high. So those are the ones that I've been going after. And I think I have about, between the 2 programs now, about 25 patients on these drugs. And I'm seeing exactly what the studies have shown. I'm seeing 50, 60, 70% reduction in LDL. I'm also having no side effects. I have one patient who I actually saw on Tuesday who was on Jason's product because it was out first. He's a guy who's 55, primary prevention, but he's had 2 deaths in his family, premature coronary disease. He's an FH and is known for 30 years. He's been on statins. When he was referred to me, that had all been in the background. I first met him about 3 years ago. He came to me off statin because he was having diarrhea from the statin. He had an upper and lower scope. Nothing significant was found, usual polyps and whatever, and screening again in 5 to 10 years. And I got him back on a statin, and then I put him on Jason's product, and he stopped it after 2 injections because of diarrhea. So I said, okay, we have another product. I don't believe it. Went through the whole thing. No, he didn't want to take it anymore. So okay, got him on the other product, and he's now had 5 doses. Doesn't have it immediately, but he has it intermittently and thinks it's the drug. And so I convinced him on Tuesday, not without effort of trying to convince him, I should say, he agreed to not come off it because of the benefit he's had. He's actually getting 60% lowering. For the first time, he's less than 2. His LDL is 1.7 actually. And when I went back and showed him all his history with the resident, and I had a pharmacy resident with me now, and she did the initial intake, and she said, he's not going to take it. I said, watch. Because I went back and I showed him back in 2014 when he came to me, or 2014, and then 2015, in that period of time, he was scoped. He didn't remember having diarrhea. And I think he has IBS. He just needs a diagnosis. And he, unfortunately, he also has a family physician who I call a flitter and a flirter. She's one of these people who, like every little thing, if you go in and he says, you know, my fingernails, dermatology, let's go. She just refers constantly. Because part of the referral back to the clinic was he was concerned his brother had a PE recently, and he thought he was going to die. He was going to have a PE. Did he have any reason? Is there a genetic predisposition, or did he have some other thing happen? He hadn't had surgery, but his family dog screened him for PE, did all of the hematologic workup for all the genetic abnormalities. And anyway, so that's the only side effect that I've actually had. I've had 2 or 3 of the patients who are quite needle phobic, which when the trials were being done, phase 2 and 3 trials, and I was approached to do one of them, I didn't really want to do it because I actually was quite firmly believing that this was not going to ever come to anything. I never thought patients, I worked enough with diabetics, I'm not a big diabetic guy, but I worked enough with people on insulin to know that it's like needles, oh my god, no way. Not a single one of patients, including the couple that had needle phobias, are bothered by it. The devices are really slick if you haven't seen them, and they're tiny. There's no visible needle. There's a little barrel at the end. They put it in their skin, they depress it. They don't see anything, they don't feel anything. So, to my amazement, 5-6 years later from the clinical trial time, patient tolerability and acceptance of it is quite good. And then because when you explain what the expected benefits are, now I can translate them into some meaningful potential for outcome benefit to them. Even just the cholesterol number change that, patients who've known about these high levels of cholesterol for many, many, many years, like the guy who had this GI problem, they're blown away that they're seeing these kinds of effects.